Thank you all for joining and for giving us an hour or so out of your day today. Today, we have the opportunity to spend a little time talking about strategies to help optimize quality and revenue, specifically for Medicaid patients, and really diving into how that can work from an FQHC strategy perspective. So I'm going to go ahead and start by just covering our agenda and how we're going to structure the time together. We'll get started with a very brief introduction of the team members that we have on today and our panel members. When we get to the panel discussion later on, we will give each panel member a little bit of time to dive deeper into their background and why we asked them to come share their expertise with you today. But I'll do a high level to get started. Then we'll give some brief orientation around challenges that you all, if you're a health system or a provider or an IPA, typically face and probably know very well. We'll talk a little bit about an FQHC overview just to give everyone on the call a basic level of understanding. And then we'll talk about one of the strategies in a little bit more depth, taking some of potential existing clinics and moving them to an FQHC model and what that looks like. That should take us through about the first 20 or so minutes of the time. And then we will have a panel discussion with our presenters after that, and then open it up to any additional questions and answers that we might have from the audience. All right, so let me just do our very brief introduction of our panel members. As I said, they'll go into more depth on their bios later on. My name's Stephanie King. I'm an assistant vice president with Popat Solutions. I have the opportunity with Kathy and several other members of our team to help drive and lead our Medicaid strategy, quality, and FQHC engagements. Also on the call, we have Steve Carson. Steve is the senior vice president of population health with Temple University Health System and the CEO of the Temple Center for Population Health in Pennsylvania. We also have Dr. Mitesh Popat. Dr. Popat is the CEO of Venice Family Clinic in California. And we have Kathy Walker, who's an executive consultant with Popat Solutions, and also serves as a CFO within FQHCs as well. All right, so before we get into content, just a little bit of housekeeping. If you haven't joined one of our webinars before, typically cover this early on just in case there are any challenges. Any questions and answers that you have during the call, you can submit through the Q&A feature in Teams. There's a screenshot below of where that button exists on the navigation bar. Please feel free to put those in. Peyton will send those over to us, and we will try to get to answer those at the end. You can also email any questions directly to info@copehealthsolutions.com. We'll get to those as well as best we can. If for some reason we run out of time or there are questions that we want to pull in other subject matter experts to weigh in on, we will send a written response to all questions received, as well as a PDF copy of the presentation and a link to the recording a couple days after today's session. So if for some reason you missed portions or you want to go back and listen to it again or share, you'll have the ability to do so. All right, so with that, we're going to jump into some of the content. Kathy and I are going to cover a few of the slides, and then we're going to move to some of our panel session questions. So we want to start by acknowledging some of the common challenges that we hear from our health system and provider partners. Most of these you all probably know very, very well. You're probably dealing with them on a daily basis, but it's important to level set the stage of why we think this is an important topic and really relevant for today. So I'll start out by acknowledging with Medicaid expansion and just overall growth in Medicaid, that's certainly pouring more and more patients into the Medicaid bucket and patients that need the type of services that FQHCs and our systems offer. We also know and have experienced that managed care contracting organizations are really pushing more and more towards rigorous quality measure and risk focus. Even in some of the more conservative states that we work in, we certainly see Medicaid organizations and payers looking at pay for performance measures, quality measures, and how they tie dollars to value. So being able to succeed in this pop health environment that we're all entering and in is really critical to being able to sustain going forward. We also continue to see increases in emergency department visits and admissions for Medicaid patients. And a lot of this time, this is tied to inability to access primary care or specialty care services. And as we go further in our webinar today, Kathy will talk about some of the specific opportunities and strategies where we've seen partnerships succeed before. We certainly see and have continued to see increasing staffing and operational costs across the board, but this is particularly felt in clinics that might be owned by providers or health systems that really were already living on a Medicaid fee-for-service world and being subsidized by other lines of business and other service lines within the organization. And as we all hear and work on a daily basis, we see and experience, and our members see and experience, a lack of consistent transitions and post-discharge, really coordinated care that ultimately brings them back into the hospital for unnecessary admissions. All of these things are really then leading into the last one, that we see that clinics serving high-volume Medicaid patients really lack the financial resources to put into place the coordinated and wraparound services that are really required by many underserved or Medicaid patients. And this is where FQHCs and partnerships with FQHCs can really step in. So we'll start by just a little bit of orientation on what is an FQHC. So if you're not aware, FQHCs, federally qualified health centers, nonprofit organizations. It's a federal designation through HRSA, the Health Resource and Services Administration Department. And FQHCs are required to provide comprehensive primary care, which includes dental, behavioral health, and specialty services, as well as enabling services, such as the ones we listed here: interpretation, transportation, care management, and others. And I want to pause quickly and talk about how this differs from some other just Medicaid clinics that might be attached, for instance, to a health system. So although the comprehensive services don't necessarily have to live within the four walls of the FQHC has to provide access for their members to those services. And the enabling services that FQHCs provide are typically well above what we might see in other places. So we'll give the example of transportation, for example. Instead of just transportation potentially home from a visit, this might be to and from a visit that happens within the FQ. This could also be to and from a visit that happens somewhere else that member needs access to. So really focused on how we get that member that comes to see us from an FQHC perspective, that comprehensive quality primary care. The third bullet here is something that you'll probably hear from our FQHC leaders that are on the call, and that FQHCs are mission-driven to serve the most vulnerable and underserved patient populations. That's key to why they exist, key to why that they're funded, and many of the leaders in FQHCs make that their mission to ensure that their organization is providing that care, which makes great partners for improving quality in the community that we serve. Lastly, for all of these services listed above and others that FQHCs provide, they are eligible to receive enhanced Medicare and Medicaid reimbursement. Kathy will talk about that in a little bit more depth later on, and purchase medications through the 340B pricing program. So before we move on, I want to just talk through why, as we work with health systems and provider organizations, we really focus on having an FQHC strategy and how that can be a huge benefit to the communities that we're serving. So certainly FQHCs we talked about earlier, they provide that primary care access to the underserved patient population. And a lot of times FQHCs and health systems, especially if they're on the nonprofit side, already have missions that are aligned to serve those vulnerable populations. So a partnership works really well to be able to expand care, also to achieve quality outcomes through accessing those enabling services that we talked about. All right, so there are two really ways that as we work with health systems and providers and FQHCs, we recommend to approach a strategy here. The first is to strengthen partnerships with existing FQHCs within the geographic footprint that you have. This can look like different programs and services that we'll talk about as we get into the panel as well. But this can look like care coordination and discharge programs and policies where we're helping those members that come to us from a hospital perspective get access to and establish care with a local FQHC. This can also look like some proactive programs around specialty care where there's a win-win. So potentially there's a need on the FQHC side to provide the specialist care, and the specialist can actually enter the four walls of the FQHC, provide care there. and then through an MSA, potentially get a higher dollar payment than they would have in a Medicaid fee-for-service clinic. And all of these things, all these different programs can help as a community us move forward to better perform in our value-based payment arrangements. The second one, and this is the one we'll spend a little bit of time on in just a minute, Kathy will touch on a couple slides, is looking at some of the high volume clinics, high volume Medicaid clinics, Medicaid and Medicare, but essentially Medicaid clinics that might be eligible to actually transition into an FQHC model. So it is a significant operational lift and governance lift to make this transition, but it certainly gives an opportunity for a clinic that's already serving that patient population to provide better quality care to the patient that is being served today. Through that enhanced reimbursement that we talked about on the slide before, and we'll talk about a little bit later on as well, can give you additional dollars to serve that population and to provide them with the right services, which then helps improve on quality measures as well. It also gives the opportunity to establish an organization, an independent organization, but an organization that's already aligned with quality and risk goals, and has the benefit of reducing the losses through the enhanced reimbursement that the current clinic is already experiencing, and allowing dollars to come back in through MSA services that clinic may need to purchase from the system or for other organizations. So those are the two we're going to spend time on in the session. And I'm going to allow Kathy to jump in and talk a little bit more in depth about the second one. It tends to be the one that's a little bit more foreign to most people. So Kathy, I will let you take it away. And if you'll let me know when you want me to advance the slide, I will do that.
Thanks, Stephanie. So really want to talk about the advantages to transitioning existing high Medicaid volume clinics. And we focus on high Medicaid, high Medicare clinics because of that reimbursement that Stephanie touched on. So with an FQHC designation, you get access to enhanced federal reimbursement through a PPS rate, which is a prospective payment system. It's cost-based. You get to establish your cost per visit, and for those Medicaid visits, that's what you're paid. For Medicare, it's a PPS rate also, but there is a ceiling on that. So it's a much enhanced over what you would see as a traditional fee-for-service Medicare practice. But there is a ceiling there on that Medicare side. So when we talk about that, just to give a little comparison, a pediatric clinic in the state of California that's fee-for-service might get $30 on average reimbursement for a 99212. A PPS rate, we're going to say in the state of California averages somewhere between $250 and $400. Can be higher based on your cost structure and how you leverage that when you rate set. But you can see there's a significant difference. And so with that additional reimbursement, we're able to start doing some other things to give back and do more for that community. Certainly those that safety net for those patients that need us the most within our communities. Most of these system practices are being subsidized. And even if those financial reports monthly show a break even or maybe a small profit to them, what we find when we dig in is that a lot of costs are not being allocated to them. You have finance departments, you have treasury departments, whatever it is, and maybe you just pass on a corporate allocation, but not really digging down and allocating all those costs. As we get that PPS rate and we start to see that enhanced reimbursement, what we're able to do is set up a managed services agreement, an MSA, and pay for those services, pay the network back for a fair market value for the services that they've always provided, and they've just never seen any reimbursement for that. There's an advantage to both sides for doing that. We get to leverage those dollars that we're paying the network to set our PPS rate, so we need those costs. We want to accumulate those costs, and now suddenly the network has a stream of revenue coming back for services they've always provided instead of subsidizing these practices. So definitely a reduced need to subsidize those practices within the system. Quality, I think with anything, as we throw more money at things, if our focus and our mission is to provide, meet our patients where they are and provide high quality care, we're able to do a lot of those wraparound services. We're able to case manage these patients. We're incentivized to case manage these patients. As we go through that rate setting process, we're trying to build our costs. And so we're in a position where we can add positions to case manage these patients, to ensure, as Stephanie pointed out, they're getting transportation services, not just within our four walls, but outside to specialty appointments, to things that are really going to make a difference in those outcomes. And so with all of these care coordination services, we're able to see improved quality and outcomes in these patients, which, as we all know, much of our revenue stream is driven by those quality outcomes. And then that new revenue stream, and I touched on that. So really, we have three parts to that. We're leveraging the dollars that we're spending to build our rate. We're no longer having a system subsidize these practices, and quite the opposite. We're feeding money back to the network through an MSA to pay for the services that they're providing, whether that be credentialing, HR, quality, all those departments, all those support departments, IT, that have always supported them. We're now going to pay for those services, and it's going to be a win-win for both sides. We can move. So FQHC models and the key federal support opportunities. So there's four models within a federally qualified health center kind of designation setup. One is a lookalike. As you see here, one's an FQHC grantee, and I'll talk about the differences there, an expanded scope, and a subrecipient. As you kind of just glance over this, you can see that they all have yeses in all the same boxes, except a lookalike has those first three that says no. So a lookalike follows and looks like a fully funded FQHC. They're held to the same standards. They get the same reimbursement, that enhanced Medicaid and Medicare reimbursement. They don't receive a federal grant. They're not eligible for the malpractice, the FTCA, which is very valuable to practices. And they're not eligible for the federal loan guarantees for capital improvements. Those three items are only accessible to the next three designation statuses. A fully funded FQHC grantee. It's all the same as the lookalike. The exception is you've applied for and been awarded a federal grant that goes with that designation. We always want to see every lookalike position to apply for a new round that comes out. And that's the desired end result. And however, there's not been rounds. We don't know when they're coming out. They used to come out much more frequently during COVID. The majority of the federal dollars went for COVID relief to existing entities. And so we are aware there's another new access point grant round coming up. It will be very competitive. And we're not sure what the focus is going to be yet for those grant dollars to prioritize it. So in the meantime, the lookalike and these other options are available until that round comes out. And I'll just touch real quickly. So the first line, the receives a federal grant, that new access point grant is $650,000 a year. It's ongoing as long as you meet the requirements of the program. And it does grow over time with things that are added, inflationary factors. Lots of times they'll come out and they'll add some additional funds to that amount every year as your base grant. Eligible for malpractice coverage under the Federal Tort Claims Act. It's basically, if you're suing the federal government, and it gets turned over to the federal government and they defend that. So it's very valuable in a few ways. It's attractive to providers for recruitment because they know they have great coverage, and it's a huge money savings year over year to a health center. Eligible for loan guarantees. We don't see that much anymore. There's funding available and loans available to FQs. We're recognized in our industry. The 340B drug program, that's available to everyone. Those are huge savings. Many FQHCs, that's their entire bottom line. This is a great value to FQHCs. We talked about the enhanced reimbursement, and then you're automatically eligible as a designated health professional shortage area, which allows you to, for recruitment purposes, to attract J1, H1 visa candidates. So we talked about the lookalike and the FQHC grantee. An expanded scope is basically rolling into an existing FQHC. There's an existing FQHC in your service area, and we roll a couple practices into them, and they become part of that FQHC. They're no longer a separate entity. They're part of the FQ. And then a subrecipient is very similar to the first column of a lookalike or a grantee. You're underneath a full grantee. So the parent company is a grantee. They have a board The subrecipient sits under that, and there's several layers there. But the federal grant is shared with the subrecipient, and that's why they are eligible for that malpractice insurance. We can move. So FQHC enhanced revenue opportunities. I talked a little bit about the Medicaid prospective payment system, that base rate. So it's a cost-based reimbursement. It sets a predetermined per visit amount for services provided by FQHCs. Rather than being that standard fee for services, we receive one bundled rate for an eligible visit with an eligible provider, and it's a face-to-face visit with a patient. And so whether you look in a child's ear for an ear infection or you do brain surgery, you're going to get that same bundled rate. You've established what your rate is per visit, regardless of the services that you provide during that visit. Eligible visits, which is very critical because that's what determines if you're eligible to be reimbursed that PPS rate, is it has to occur within our four walls. There's been some change to that through COVID, right? We can do some remote visits, et cetera, but for all intents and purposes, it's happening within the four walls of our health center. It's a face-to-face visit that's been rendered by an eligible provider. So it's not a nurse visit, it's a provider visit. And then services are rendered within an approved scope. So we've asked for and been granted approval for a scope of service, primary care, behavioral health, whatever that might be. And that's what would be eligible. That Medicare I talked about, it has an upper payment limit that's geographically driven by Medicare. But you see there approximately $195 a visit, still significantly better than what we see with traditional Medicare fee-for-service. Managed care organizations, value-based contracting, lots of opportunities, quality programs, all of our quality dollars stay outside of that PPS rate. So we do have opportunities outside that PPS rate to kind of mine some additional dollars and earn additional monies that we're willing to work for with our quality and our outcomes. And then just talking about risk savings linked to quality, lots of FQHCs across the country are really starting to invest in risk contracts. We're willing to work for our money. We know our outcomes. We know our providers do a really good job, and we case manage our patients. And so we're a great partner with risk programs to keep patients out of ERs, to bring specialty care within our four walls. All of those things. If we don't have access for our Medicaid patients to specialists, because the specialist doesn't get paid enough to prioritize those patients, we can bring that specialist within our four walls, and suddenly we're getting a PPS rate. We can pay that specialist what they deserve, what they're worth, and our patients have access, which dramatically changes the outcome of our patients and our HEDIS scores and our quality indicators. So a win-win again for both. We can move, Stephanie. Oh,
you have anything else to add, Kathy?
Nope, I'm good.
Okay. All right. So as promised, kept the slides short, and now want to move into some questions for our panel. So Steve and Mitesh will be joining us for this session. So wanted to start off by asking if you each would share a little bit more about your background and your experience, just for order of who will go first to make it clear. Steve, we'll start with you and then let you hand it to Mitesh, and then Kathy, we'll let you go from there.
I think Steve's muted.
You're mute.
We'll try that again. Good afternoon, everyone. My name is Steve Carson. I'm the Senior Vice President for Population Health for the Temple University Health System. I'm a registered nurse by primary education. I had been in the value-based world long before we called it value-based for at least 30 years. I've been working in some strategy related to risk contracting, and care management programs. I have been focused on community care programming through some of the work that we're doing here at Temple Health, particularly around focusing on the social determinants of health. As part of the FQHC strategy for the organization, I was the executive lead for the transition of 6 of our practices into a federally qualified health center preparation for becoming a federally qualified health center look like? And
Mitesh, we'll let you hop next.
Okay, great. Thanks. Hi, everyone. My name is Mitesh Popat. I'm CEO of Venice Family Clinic. We are a pretty good-sized FQHC in Los Angeles, along coastal LA from Santa Monica down to Torrance and inland for a good stretch. I've spent much of my career, pretty much my entire career, in federally qualified health centers. I'm a physician by training and a public health person. And so I come to the work kind of finding that balance between the finance elements that have been discussed at length and also looking at quality, looking at effectiveness and delivering healthcare services to the underserved communities that we serve. Couple things that come from our lens. We don't tend to talk about it as enhanced reimbursement. We talk about it as adequate reimbursement to care for our underserved, high need populations that we serve. And as you can understand and imagine, patients that we serve are most challenged with the social factors affecting health, as I talked about it in my master's degree write-up. Now we call it social drivers of health, right? So our patients are the most challenged in those areas, and thus it makes sense that it requires more resources to care for those individuals. And we've been shown to be quite effective as far as cost savings to taxpayers, to the system downstream. So I would like to highlight that point as well. And as a colleague of mine from the South said at a conference while we were debriefing late at night, I won't say what we were drinking, but he said to me, finance without romance is a nuisance. So I'll just end on that point that we got to talk about the romance and what we do at community health centers and federally qualified health centers. We are able to really drive and going back to the dollars, bring dollars into local communities from the feds and the state. This Medicaid program, as you all know, is a shared program, and help deliver impact in our local communities in a way that is better and than can be done without us. And that said, we do need tremendous collaboration with our health system partners for all the reasons that I think have been elucidated thus far. So happy to partake in questions later. Thank you.
Kathy, you want to go ahead?
Yeah, thanks, Mitesh. So I'm Kathy Walker. I'm a CPA by training, accounting degree. Started my career off in the hospital world with a large hospital organization in Northern California. I was born and raised very rural farming communities. And I spent about 5 years in the hospital, and I really longed to do something closer to patients. I had an opportunity to join an FQHC in my community as a CFO 25 years ago plus, and I've never looked back. I'm passionate about FQHCs. I've seen it make an impact in my small rural communities as well as across the nation. I had the opportunity about 22 years ago to spin some practices off of our local, it was then privately owned hospital into an FQHC, fully funded, and they're still robust today. And I drive by it every day. I live in a town with 2 stoplights, and I drive by that clinic every day, and there's patients waiting outside to get in. And so that's what drives me. That's what makes me passionate. I don't have a mindset to be a clinician. And so I've felt like I've had the blessing to be still close to making a difference in the community with community health centers. And then together with COPE and some of the other work I've had the opportunity to do to spread that across the nation in little sprinkles, but enough to feel good that we are making a difference. I'm super excited to be here. I'm always excited. I know I make Stephanie nervous because I can just go on and on about when I start to feel good about what we're doing and want to share that. So excited to be here. I look forward to the remainder of my career being in making a difference in communities by partnering with FQs.
Thanks, Kathy. All right, I know a panel is a little tough in a remote environment, but we will we'll drive through together. So this next question is for all three of you. So can you each share a little bit more about your perspective on why FQHCs are really poised to improve quality and benefit the patient population? I know you touched on it a little bit, but maybe go a little bit deeper from your own experience. Mitesh, will ask you to do that first, and then Steve, we'll go to you from there, and then Kathy can add anything.
Sure. So I think people think of federally qualified health centers or community clinics probably from the vantage point of free clinics, and so that's sort of an important distinction. In the clinic that I oversee was indeed a free clinic once upon a time and had its own transition to becoming a federally qualified health center. So the difference is a greater degree of sophistication and a shift away from episodic care to one and avoiding hopefully people waiting in lines and not having any sort of organization to the care, to having scheduled appointments, having people having a primary care provider that they get to know and they get to see on a regular basis, and then elevating towards doing more population health work and empanelment kind of work and gap closure and all those sorts of important things that drive quality. And we're able to do that, of course, because we are able to draw down that adequate reimbursement. So we can make some of those investments in our care teams as well. We can have more robust care teams instead of having absolute lean, bare bones staffing, where I've seen in some practices that have been predominantly Medicaid, but not an FQHC. They might have one medical assistant supporting 3 doctors or something like that, versus in our model of care, we are able to, because we have a cost-based reimbursement model, as was mentioned, we're able to have an adequate care team where we have sufficient medical assistant support, nursing support, integrated and embedded behavioral health teams to really try to provide comprehensive care to the whole patient. So it's, as we all know, it's more effective to do in-reach when the patient is at one of our centers than to have to chase people down outside and have to outreach. So by having more comprehensive approach and integrated care and having the whole care team model, and then developing strategies around really complex populations that have special needs, such as unhoused populations, such as people that are hard to reach. We talk about school-based health centers, we talk about seniors. So we can innovate in a number of different ways to deliver programming of various sorts and to have a reimbursement model that can back it up in the aggregate and in the long run is helpful and allows us to have a lot of innovation in our sphere. And we tend to not be as big as these health systems that many of you may be coming from. So that frankly spurns more innovation. And we tend to be, and we're required to have a 51% majority patient board, community member board. So these things all result in us being closely rooted in our communities and responsive to our community's needs, and having a mechanism and model of reimbursement that backs it up, as I said, and supports it. So I think all of that tends to drive toward better quality, and we have to do the work still, and we are still challenged with workforce shortages and all the other macro environment challenges that we've all faced with COVID and so on. But it does help to have the backing of the federal government. Literally, we were able to draw down funding through the COVID relief funds that came through. There were a tough few months, just as for everyone, but we quickly had the backing of HRSA, the Health Resources Services Administration, and the federal government backing us up and making us reassuring us that we're going to be able to get through this difficult time. So I think that was, to me, a kind of an illustration of the value of an FQHC, of having that status. And anyway, so I'll stop talking and let someone else go.
Fantastic. Steve, we'll move to you to see what you have to add.
Great. Thank you. I'm going to add a few things. So first, I want to think about where, from a Temple perspective, when we look at where we live in our community. When you think about the city of Philadelphia, we have 4 large academic health systems in the city of Philadelphia, but within the zip codes in which we serve at Temple Health, our primary care practices that are employed by the health system are the practices that are there in the community. There are federally qualified health centers that are within our community, but there's nothing in between. And the important point here to understand is the fact that by virtue of the fact that federally qualified health centers have a different type of reimbursement, they're able to continue to provide access to care. And I think that that is really the critical importance here when you think about the value of federally qualified health center, how they improve quality, but also the maintenance of access. Kathy made a really important point about, many health systems are subsidizing their primary care practices, and they may not always account for everything that they're doing, but in the course of that subsidy. So if the health system wasn't subsidizing these practices and they didn't exist, you'd have a lower level of access in the community, and the federally qualified health centers are really there to be able to pick that up. So the importance of having a federally qualified health center is really about access in my mind, and then looking at the additional services that they are able to provide, particularly from a quality perspective, because there are requirements for quality for federally qualified health centers. As an individual physician practice, a singular practice, there isn't a requirement there. They're not there always to be able to pick up those things to improve the quality or improve access, where those requirements that HRSA overlays into the requirements are really stiff and make sure that you're able to meet those objectives. So when I look at the value, it's really a value from the community I serve, who is 86% some type of governmental payer, who people don't typically have access. Their average the median income is $24,000 a year. So this provides access that people would not normally have. So that's why I think they're critically important.
So all of that, and the only thing I'll add is, in a lot of parts of the country, and certainly where I am, and I know, as well as the other 2 panelists, there's a lot of our community may not have legal status, and with that enhanced reimbursement, it allows us to take care of that population that struggles to get coverage and to have any sort of coverage, but then also to pay for those services. So they tend to not until it becomes an emergency room visit. But I think we build those relationships in the community, and so they trust us. They'll come to our health centers for care. We deliver a lot of the babies. We take care of the pediatrics all the way up through adulthood generationally. And that enhanced reimbursement allows us, whether they have funding or not, to take care of that population. And that's our population, that's our community. And so to me, that's just a vital piece of that safety net.
Thanks, Kathy. Okay, Mitesh, I have one additional question specifically for you, and then we'll share the wealth around as well. So, as a successful FQHC in Los Angeles and serving a lot of patients there, can you talk a little bit about what you're looking for in a partnership with a health system, and a little bit about the relationship you have with UCLA today?
Yeah, as far as health system partnerships, I think there's kind of multi-layers that we have there's kind of the community benefits angle. We have some relationships like that where we receive community benefits from our health system partners, which are well appreciated, and we are great investments in the community, as has been mentioned. I think when I think more strategically, I think some of the things that have been raised are things that we think a lot about and try to improve upon. So things like care transitions, complex care management, and we all come at it from different angles, I think, a little bit, but they all are valid, and there's alignment oftentimes on the incentives on these sorts of points of improving ED to home, hospital to home transitions, trying to prevent bounce backs to the health systems. work around improving quality. So I've been involved in some initiatives around that where there's been shared incentives from the state to health systems and to FQHCs to improve quality performance on things like diabetes or breast cancer screening and things like that. So I think there's some opportunities there. And then a lot of the specialty care work that's been mentioned, I think, is a real opportunity to try to think a little bit more strategically, as opposed to having people continually show up in the emergency department with dental pain and back pain, and people with bad hips continuing to show up in the emergency department. I've worked successfully in the past with health systems to try to embed specialists in our outpatient primary care clinics. And FQHCs have their primary focus is a primary care mission through under HRSA, but under that we're allowed to deliver specialty care services to the extent that they deliver and improve that primary care access. So sometimes you can't provide good care to the patient if they don't have the specialty care access. So I think I've been in the past been able, and now at Venice, we've got a cardiologist and a pulmonologist that are coming through the clinic. And the good thing about that is the patients don't have to go to primary care practice, the specialty care practice in the community. And the complaint of community specialists often is, well, we don't have linguistic capability, or your patients no-show a lot, and they're hogging up access. And so the simple solution is you come to us or send someone from your group to us. And sometimes it's a senior clinician, sometimes it's a physician assistant. So there's different solutions that we've employed in the past to do that. So I think that's a value to our patients. Obviously, they're reducing human suffering and improving access to healthcare. And it's also reducing utilization that's maybe inappropriate or what are misplaced, and where people are showing up in the emergency departments. And as far as our relationship with UCLA, we have a unique 50-year affiliation with UCLA, and we've got some collaborative dialogue going on currently about some of these things. Some of these specialty arrangements that I mentioned are through UCLA. So I think there's a lot of opportunity for value-based arrangements as well that I would say at Venice Family Clinic we're only scratching the surface on at the current time, but going through a strategic planning process, and that may be on the docket for the future. So a lot of potential with collaborations with the health system partners.
Thank you. And Steve, the next one is specific for you. With the work that Temple has done with the CIN, can you talk about how Temple has looked to partner with existing FQs in the market, and some of the innovative approaches that you all have built as well?
Yes, thank you, Stevie. It's a great question. Temple has been working in the North Philadelphia community with our federally qualified health centers long before we even thought about, rolling off several of our practices to work towards becoming a federally qualified health center. And I think what was important that we were doing is really focused on the quality of care that was being delivered. We have a contract with one of our third-party payers, which is specifically focused on how to improve quality outcomes with our community-based providers. So it's a combination of individual physician practices, but we also have a group of 5 fairly qualified health centers. And things that we're focused on are very similar, as you just heard. We're looking at HEDIS measures, how to improve screening for mammography, colorectal screening, the diabetic measures, managing hemoglobin A1C, and blood pressure management. And most recently, we just started working with our FQHCs with regards to collection of data around the social determinants of health, to collect those data and then be able to provide them a tool, if you will, to help them access community-based organizations, which their patients and their practices would benefit from. So it would help support their social service teams that are in those practices. And then part of that work is, the reason why it's a contract is because while we're working with these practices, if they do a good job, we're able to provide them with an incentive to improve their health outcomes. So it's a different way to improve quality outcomes and stay focused as a practice group. So we've been actually pretty successful. We've had this contract in place, I want to say it was pre-COVID, so we're 2024. So maybe since 2017 was when we first started doing this work. Initially, people weren't sure how to work with us because we were the health system, but over time, we employed a manager who actually went out and worked with the practices and discussed how to improve transitions of care, how to close those gaps in care, and work in alignment with each of the practices so we could help them improve quality as well as help them have a different opportunity for funding through incentives. So it's actually been pretty successful. We've also connected each of these practices to our local health information exchange. So when their patients are admitted to a hospital, doesn't matter which hospital, whether it's a temp facility or it could be one of our other competing hospitals, they now know their patients in the hospital, what hospital. So from a transitions of care perspective, they can do outreach while that patient's still in the hospital and connect. And then we also help support them with any of their patients who actually come to a Temple facility to make sure they get that information back and get a daily notification from us. They're in our ED. This is what happened. And so actually it's become a very good relationship to be able to share this information and then help improve overall outcomes within our community.
Thank you so much. I know we're going to be a little short on time, so may skip around on questions to make sure we can also get to a couple for the audience as well. Steve, so if you don't mind, I might pick your brain on another one from you. You mentioned at the beginning that the Temple is in the middle of pursuing the transition of some of the clinics. So can you talk a little bit more about, what the driver for that was, and about the impact that you think that will have on the population that you all serve?
Great question. So a couple of things. I think from a sustainability perspective, it provides the ability for these 6 practices to be sustainable in the community on long term. These were practices that we provided a lot of services in. We did care management. We had integrated behavioral health. We did a lot of the work that we needed to do in these practices, but none of that work was reimbursed. It was the right thing to do. So I think as we look at how we continue to proceed with our Fair Health Community Physicians, which is the practices that are transitioning, I think it provides them with the opportunity to be sustainable and continue to deliver the care management, social work, CHW, community health worker services that are provided. In addition to that, it's something that's going to allow us to do additional growth, add in services that we don't have. Dental care, we've spoken about dental. There is a dearth of dentists in our community, and it would be a really great opportunity to be able to use this funding to help expand and include dental services other than through a contractual relationship with a dentist. So I think that, so from that perspective, it really helps sustainability. It also helps with the relationship with the other federally qualified health centers in the community. We've spent time with each of the other FQHCs in our community, to gain their support. It's really important that they support you in this process and how they view you and view the work that you're doing. So, from that perspective, it's been really important for us to gain that support and align with the other federally qualified health centers. So we're working in tandem with them and not opposite to what they would want. And probably most importantly is the quality component. I think that is really the key process. You've been reinforcing that message throughout this afternoon session, that the quality component is critical. And as far as the ability to provide that solid service to individuals who don't normally or would not normally have access. The one thing we have not discussed is this sliding fee scale, which is Kathy touched on a little bit about immigrants or people who are who don't have a citizenship status within the community. But that sliding fee scale creates a level of access that people did not have before. I will be transparent and say that we had a sliding fee scale, but you had to work really hard to go get it. Under this new policy and structure that have been created by Fair Health, it creates a better level of access, a little bit more open transparency, and make sure that that individual arrives at our doorstep, that we acknowledge their financial status and make sure that we give them the access to the care that they need. And I think that that's probably, when you think about what's going on in our local community, when you have individuals who have a low median income, that is critically important.
Thanks, Steve. And Kathy, I know you mentioned at the beginning, you've done several of these in your career as well. Anything that you want to add to that?
Right, the only thing I would add is just, I'm going to tee off of what Steve said. As FQs, we're not competing with each other. There's plenty of patients to go around. I think most of us try to stay within compliance with the managed care organizations for that third next available, right? I mean, there's a lot of demand, more so than we've ever seen in history, at least my experience. But the one thing I wanted to also add around collaboration was those partnerships. I mean, we get paid well as FQs to take care of a patient population that's in great need, where others don't necessarily reap those benefits. I've had a couple of actually about 6 or 7 opportunities to partner with hospitals and large hospital organizations, and we actually built FQs across the parking lot from an ER. Or across the street from the emergency room. Most emergency rooms are inundated with patients that do not require to be in the emergency room, but they don't know where else to go. They can't navigate life to figure that out ahead of time. And by putting that there and being in the face of those patients and available and accessible with hours that are accessible, that partnership, it relieves that ER from being on diversion. Or whatever we want to call it, everyone uses their own words. It ensures that patients who have emergencies can get in and get taken care of. And it puts a lot of patients in an appropriate level of care at a reimbursement rate that's sustainable. And so it's a win-win for everybody involved in that equation. And I've seen it be so successful where those investments that the hospital are making, I mean, they're recouped just over and over again over time with the savings that are realized through those inappropriate ER and clogging up our ERs. So that's just one thing I would add, but all great points around the collaboration and care being provided.
Thanks, Kathy. All right, so we only have 5 minutes left, but we did get a couple from the audience. So at least we'll try to get to one of them, and we'll open it up to all 3 of our members of the panel for whoever would like to go first. And then if there are other questions that have come through, I've seen at least 1 or 2 more. We will make sure to provide answers to those from our panel in the Q&A document that follows. But one of the questions was, this actually came in twice. Can you talk a little bit about some effective strategies for closing gaps in care for the Medicaid population? So we'll open that up to any of the 3 of you to jump on that you'd like to speak first.
I don't mind jumping on that first. I mean, I've been working within the Medicaid population for a really long time. And I think there's a couple things from a strategy perspective that are really important. One is your infrastructure. So how you set up your information systems for best practice alerts for your physicians and your physician assistants or whoever are providing care is to be able to make sure that you're queuing those best practice alerts up for the patient population. Your pre-visit prep is extraordinarily important. Knowing what gaps need to be closed on those patients who arrive. Some people do pre-visit prep on paper, others are able to do electronically, but at the end of the day, that pre-visit prep is critically important to be able to help close gaps. We do, within our own organization, FQHC, non-FQHC, have a fairly robust infrastructure that we have people assigned to each of our practices to be able to, work with our physicians and the providers and say, this is where we are overall for them. So we look at it monthly. They do monthly visits. So we have our chief medical officer spend some time with them quarterly, but we have practice quality coordinators who meet with the practice on a monthly basis and say, here's where you are today. Here's your goal for tomorrow. And this is what we anticipate. I would say on average, even with all of that work, we probably are able to achieve about 75% of those closures of gaps in care and to meet those objectives around HEDIS and STARS measures in particular. Medicaid is a tough population. We also are big on utilizing transportation resources to help people, get into the office if they're not going to get in. And for those things that could pivot to a telehealth appointment. So if I miss an appointment, someone in my office is calling you and saying, hi, You missed your appointment. Can we do a telehealth appointment instead? And if we're able to accomplish that, particularly if it's around a physician order for a screening mammography or a colorectal screening for a start to meet a STARS measure, those types of things that are in there. So we have tried a lot of variety, but the infrastructure around a quality manager, working with the team, best practice alerts, and that pre-visit prep process is extraordinarily important to meet those objectives.
Thank you so much, Steve. Mitesh or Kathy, anything that you would like to add?
I just think over the years, I mean, the quality in FQs, it's changed significantly. If I think back to when I started my career, FQs were focused on volume, right? Visits. We were paid by the visit. Those days we all know are gone. For the benefit of the patients, for requirements through the managed care plans, through HRSA, our UDS reporting, we're all looking at quality. We all want those outcomes, and so I don't think if you go from the hospital practices, affiliated practices, the FQs, I think you don't see a lot of difference there, other than FQs can afford those wraparound enabling services to really focus on those social determinants of health, and get those outcomes that we're all desiring.
Yeah, the only thing I think, Steve, you all both hit the nail on the head. I think to that question, I think internal processes when the patient is there, involving operational process and technology that Steve mentioned, and then panel management work. So kind of once a month, some periodicity, the teams get the data on the gaps and they can reach out. Doesn't have to be the physician, could be the nurse, could be the MA, could be whoever, and then centralized approaches. So things that are around cancer screenings, mailing the fit kit to someone's home, or ordering a lab test to tell someone, and then telling the patient they can go get it done, outside of any sort of clinical encounter, things that you could kind of centralize. So that's sort of some other ways of thinking about it, and sort of concentric circles a bit.
Thank you all so much. I know that we're at time, so just really wanted to thank all of our 3 panel members. Appreciate the time and prep leading up to this. And for everybody that was able to log in and attend, thank you so much for your time. There were a couple more questions that we didn't get to today. So like I said, those will come out in the Q&A along with the recording and the PDF of the slides in a day or so. Our information is here, so if you have any questions that you wanted to ask but didn't have a chance to, please feel free to continue to send those in. And thank you all so much for your time. Mitesh, Steve, and Kathy, thank you all very much.
You're most welcome.
Thanks for having us.
Thank you.
Thank you.